Thank you, and welcome to NUS ISS, Untangling the Web Systems Approach to Healthcare's Wicked Problems and Digital Solution. It's lovely to see everyone, and a warm welcome to you and to our esteemed guests. I'm Bethia, lecturer from Digital Health Practice, and I'll be your host for today. So now let's begin with a very simple question. I know many of us here are healthcare professionals. Can I have a show of hands? Who is actually a user of our healthcare system? Or perhaps you are actually a caregiver, so you interact frequently with our healthcare system. Anybody in the room? Yes, I see a few hands here and there. Thank you very much. Now, of course, to those of you who raised your hands, so can I ask how many of you actually felt frustrated by our healthcare system? Okay, yes, some giggling, chuckling here. We all get it, okay? I get it too. And for some of us, navigating the system can be a daily struggle, myself included. For example, fighting bureaucracy, digital systems that don't talk to each other. Or you may even come across policies that sometimes make you wonder, who designed this, right? So let me now begin with a personal story. There you go. So here's me and my grandmother, whom I lovingly call Papa. A couple of years ago, she fell at home and was admitted to the hospital. To give you a little bit of context, my papa is a widow. She lives with her domestic helper. She had 5 daughters who each had their own family. So they take turns to look after my papa at home. So after the fall, they rotated the visits to the hospital. So it's not uncommon, right, that my aunties then will make it a trip to the hospital every morning to catch the doctor when they're doing their rounds to get an update. But even with the best planning, sometimes there were occasions where they don't see the doctor doing rounds. And what they would do, like many concerned family members, is they call the ward they blast the lines actually to get an update. Now, as many of you know, right, a hospital allow only one NOK or next of kin to be registered as the point of contact. As I mentioned, my papa had 5 daughters. Imagine it's not that daughter that's calling, it's the other one of the four who calls. So you'll be basically an exchange or rather a tussle between them and the healthcare or the ward people about, the legitimacy of their identity and then their relationship with my grandmother. So it was quite a struggle. And this is not something that's unfamiliar, right? So I remember thinking to myself, why can't we have an online system or online portal for real-time updates? Instead, why do our caregivers or us have to, fight with this doctors or whoever there's on or the ward staff just to get a simple status update? Yeah. So so fast forward a little bit. After a series of tests, we learned that my papa got a weak heart and irregular heartbeat, and this is why it caused her to feel dizzy and which resulted in the fall. And for the treatment options then they were given 2 options. 1, insert a pacemaker, or 2, manage the symptoms conservatively. As you can see, my papa was already 89 at that point. Doing an open heart surgery was considered very high risk. So my aunt decided that, okay, we're going to manage the symptoms conservatively. But that was when the real nightmare began. So after her discharge, there were medical appointments piled up. Cardiology for a heart condition, endocrinology for hyperthyroidism, physiotherapy for her rehab because she had a fall and suffered a fracture, and polyclinic for her chronic disease. She had hypertension and high cholesterol. So you can imagine, my papa, her frame is not exactly very small. It's quite a challenge, and she's not very mobile. So it was quite a challenge ferrying her from appointment to appointments. And my aunts, just for your info, they were all in their 60s themselves. So you can imagine the challenge there. Okay, then came another challenge. So over time, her condition deteriorated. We can see that she lost a lot of weight. So we make the visits to her house quite often. So that's me and my elder daughter there. So you can see from just now the earlier photo, where she's still a bit rosy, a bit fleshy, to now she has lost her weight drastically. And we all know when old people stops eating or eats very little, that signifies that something is brewing and is very troubling. And so none of my aunts or even myself who used to be from the healthcare industry knew what to do. So naturally, my aunt called the polyclinic because that was the last place where they had their follow-up appointment. So they called and say, can I have home nursing support? only to be met with a lot of bouncing here and there. They were being directed from one department to the next, then ultimately being directed to AIC, which was the correct department. Now, what I'm trying to say here is that the whole experience that they get, or rather we get, it's very frustrating and can be overwhelming for our caregivers. And this is a reality we face today. Our healthcare system, even though it's filled with dedicated and hardworking professionals, um, who wants to do the best for our patients, but in the process, we find ourselves getting caught in this a web of fragmented workflows, unintended inefficiency, and systems, that doesn't solve the problems it was intended to fix. Yep. So that is why we are here today. This seminar is about untangling the web. It's about breaking down silo, bridging the gaps, and also leveraging technology in a meaningful way. But more importantly, today it's about conversations. It's about sharing insights, learning from each other's experiences, and challenging the way we think about healthcare. So now first, let me introduce our speakers. We have a fantastic lineup of speakers, experts and leaders who are no stranger to us. So first, let me introduce Adjunct Associate Professor Ng Yok Fan, Director and Head of Corporate Development at Khoo Teck Puat Hospital and Yishun Community Hospital. Yok Fan brings extensive experience in healthcare strategy and organization development. He's a key driver in systemic healthcare transformation and value-based care. Next, we have Johan Sapanil. As Head of Health Innovation at the Institute of Digital Medicine at Yong Loo Lin School of Medicine, Johan specializes in bridging the gap between digital health's theoretical potential and real-world impact. His work explores the complexity of adoption, systems integration, and decision-making in healthcare innovation. We also have Adjunct Associate Professor Sean Lam, Deputy Director of Health Services Research at SingHealth. Sean has over 20 years of experience in this field and leads a team of data scientists focused on enhancing patient care and outcomes. Today, he will share how digital health and systems approaches can enhance systemness in healthcare, transforming uncertainty into opportunities for innovation and resilience. Last but not least, Mr. Glenn Neo, Director of Innovation and Capabilities Enablement at Synapse. Glenn has been recognized as one of Asia's top 100 digital leaders in the Visionary Leaders category. He has played a pivotal role in shaping Singapore's healthcare technology landscape. Today, he will discuss how Synapse's HealthX enablers scale innovation for real-world impact. So let us all give our speakers a round of applause. Okay, so without further ado, I know I've taken up a lot of time, so let's welcome our first speaker, Adjunct Associate Professor Ng Yok Fan.
Thanks, Becky.
Thank you.
Yes.
Hello, hi everyone. Chan Ming, thanks for inviting me. ISS team, thank you very much for the invitation. I'm very glad to be here. I actually see familiar faces and old colleagues. I'm so happy to meet some old friends as well over there. So, Betty, thanks for sharing that story. I will try to weave it into the unified care model if I can. You can read about me online. So I'm not going to talk very much about what I do, but I've spent about 25 years in healthcare in Singapore from the Ministry of Health. And then now the last 10 years in Khoo Teck Puat Hospital, previously known as Yishun Health. Yeah, so a lot of this experience that I have about whole systems work, whole systems transformation was from the last 10 years of experience leading hospital transformation into population health systems, community transformation, leading the transformation of care models within the hospital and the connection with the outside as well. And that has gotten me to learn not just about systems thinking, but also complexity sciences and systemic innovation, design thinking. I think they somehow all come together, and I hope to be able to give you a little bit about how I think about all these interrelated disciplines, skills, and capabilities. Yeah. So you might have heard this, right? Almost all the time we have lots of pilots going on, pilot already, then pilot again, then pilot already, then next year pilot again, change the leader, pilot again, right? And lots of transformative projects that seems to be always starting well intentioned, going very well for a while, and then somehow halfway through we rebrand them again, right? So and the latest one we have Healthier SG. So I say this without any belittling about how difficult all these things is, and I actually am quite gladdened and actually am quite positive that actually we are making good progress. Yeah. So, but it is in the details and how we look at these things that can help us see it in the positive light. So I'll try to frame some of that as I proceed. Um, so we know that change and transformation is really, really difficult because all of you are aware that it's both technically complex as well as socially complex, right? So it's the top right hand column there where I put a yellow box there. So some of you may have, those who have been trained in this, you will know that it's called wicked messes, right? For its high dynamic complexity as well as high behavioral complexity, yeah? And this model comes from Ackroft, Russell, as well as George Roth and Peter Senge. So, um, so a little bit more about this social complexity, right? How many people believe in this? If you look at this diagram, it says, just because you are right does not mean I'm wrong, you know. You just haven't seen life from my side. So right at the bottom there is a number. So you think it's 6 or 9? Yeah? So so how many believe this way of thinking about it is correct? Put up your hands. Yeah, okay, wonderful, right? So, but of course, I'm not going to make it so simple, right? So, so somebody therefore then says, no, 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 no. But one of those people have to be wrong, you know. Someone painted a 6 or a 9 by intent. You just need to back up a little bit, step further away, look for a mountain. Is the 6 facing the mountain, or is it? No, how do we orientate ourselves, right? Find out the intent, dig a little bit deeper, and then there should be some objective truth in this, right? For so that we can socially understand each other. One of us has got to be right. There must be some perspective around this, right? So many believe in this. Show of hands. The absolutist or the utilitarian or the whatever. No judgment again. Yeah. But then again, then somebody says, well, also that is also not true because almost nobody believes in absolute relativism of ideas. You know, is shaped by culture, is shaped by practices through time. And what is culturally accepted in one country, in one religion, in one area of practice, may not be acceptable in another area of culture, training, or practice. You know, so and then when you bring all these people with diverse perspectives into one room and ask them to work together, you have social behavioral complexity. Okay, and different people really think about problems differently. Now, so when we come to healthcare, and like I said, healthcare 25 years, so I have kind of like had enough time to see multiple things happening, right? So when we work with systems, I find one particular framework that's really helpful for us to think about what is actually going on in our large complex systems at any one time. Is this three horizon framework by Bill Sharp. So you see H1 up there, maybe that is the current system. And in the current system, we are consistently considering how to refine, how to improve, how to assure, right? Assure the standards, right? And then, but at the same time, there's always someone in the system who's developing a new way out, somebody trying to demonstrate new pilots, somebody trying to disrupt current reality, right? That's the green line that's slowly going up. And even right at the bottom, the H3, Horizon 3, there's going to be somebody working at the research front, pushing the boundary, exploring new capabilities, the collision of two different sciences, right? And envisioning new possibilities that currently don't exist. Yeah. So if you take at any one point in time, say for example say today in my system in KTPH-YCH or today in NHG, you are going to have pockets of the future already happening in your present. So I have 60 HODs 120 teams and 5,000 people in my hospital system. There are going to be people talking at the complexity of issues from the technological as well as the sociological point of view from all multiple perspectives, right? So you don't know whether they are talking about Horizon 1, Horizon 2, or Horizon 3. And worst of all, they use the same language. It's all about care. It's all about nursing care. It's all about emergency department visits. It's all about inpatient care. Are you on Horizon 1, Horizon 2, or Horizon 3, right? So it really, really confounds the difficulty. So because of all this, right, I'm thinking about how do I very simplistically communicate the problem that we are actually faced with. So just a couple of years ago, I coined this, what I call deep learning and problem solving framework by bringing together multiple frameworks. Yeah. So you see PEL there, performance experience learning, right in the middle. Performance experience learning is a framework from Galloway. And for performance, I further break it down to learn about performance, you really need to get into systems thinking, right? And you have to talk about the parts, the loops, and the whole, and understand how they work together with each other. And then to learn about experiences in your teams, in your organization, you really need to get into the issues of love, power, and justice, right? So love, power, and justice is from Adam Kahane, right? A skilled vertical horizontal facilitator. And then when you are able to manage these contexts in your teams and in your organizations, then you are able to then more easily move your teams, right, into meaning, identity, and joy. And that's from Andrew Solomon. And then you repeat the cycle, right? When you have meaning, identity, and joy, right, in your teams, in your organizations, then you put up a positive feedback loop to want to learn and move forward. Yeah. So we really have to get skilled in systems and also managing the experiences in our organization. So I therefore came up with another framework called the Health System Transformation Playbook, where we incorporate design thinking, right, as a way to really be empathetic to people's needs, right? Whether it's the patient's need, the staff needs, different department needs, right? So we empathetically describe possible solutions for solutions, right, into the scale of multiple subsystems and then align the subsystems using interdependent models. And then finally, you have a model of reality that you want to have in the future. It has not come into play today, but it's something that you are moving towards in the future. You then iterate and then you use complexity management and find a path forward. So if you are able to do all these three iteratively at scale, then I think you have found a way to accelerate and forward to untangle the wicked mess. So I have prescribed 3 simple steps to do this in this paper that I wrote. If you scan the QR code at the bottom, you can download the whole paper. Essentially, it starts with storytelling, right? So it's not just my story, but it's everyone's story, right? And you can bring these stories together, right, using skilled facilitation and genuine unpacking of the love power dynamic issues, right, to enable everyone to tell their stories. And then after that, you work on what I call group model building. You model the future together, right, in the different subsystems that need to work together to produce the outcome, whether it is the care system, the digital system, the manpower system, or the financing system, right? But make sure all these models of the future are interdependent and work together to produce your outcome. And then you continuously find paths that are possible for different teams to move towards those models, constrained within their current reality somewhat, but continuously finding solutions towards the models, right? And then the story repeats, right? Because you're going to have successes towards the models, you're going to have small little successes emerging. So as they emerge, you tell new stories. And with new stories, you move on the cycle, rebuilding the models and then re-pathfinding, and then you carry on. So I crystallized this HSTP process, the three-step process, essentially from my last 10 years of experience, trying to get the system to change and transform towards the desired models that my stakeholders have come up with, right? So this is kind of like a crystallization of the thought processes. So I welcome discussion and critique, and we can together learn about accelerating health systems transformation. So I want to now share a little bit about the model that came from the HSTP process. And this is where I want to link back to Betia's story, lah, right? Betia's granny, essentially when Betia's granny had a heart failure event or heart condition event, right? And is admitted to the hospital, that should belong to the purple dot at the bottom, which is called an episodic event, right? So in the hospital, you will see a lot of patients that ideally belong to different, what I call episodic segments, right? And then the hospital will do its job to take care of the patient and return the patient back to what I call a lifelong population. And in the lifelong population, you essentially can do the same thing. You can segment the lifelong population of maybe 1.5 million people living in the north of Singapore, right? Or 1.5 million people. You can segment them into different population segments. And Betia's granny would belong to a more frail, more older population in the lifelong care segment, right? So once everyone is in a segment, right, then you can plan systematically towards what is a better outcome for Betia's granny in the lifelong care segment, right? And if she is admitted again, what is a better outcome for Betia's granny in the episodic segment? So when taken together, you actually see two subsystems working together to produce a health system for which you now have targeted strategies for lifelong care, the green part, and you have targeted strategies for the purple part. And I think this is a basis for many other models. So for example, I have divided my systems outcomes measurement similarly into these two subset systems because this is a digital savvy population, right? You guys are interested in IT, data, digital innovation, and technology, right? So we can conceive of the purple one on that side, where you need to think about what sorts of technologies measurement do you need for the purple subsystem of episodic care? And what sort of digital technologies and measurement that you need for the lifelong care subsystems and at the different levels of the systems, from the micro systems at the bottom, and then aggregating the data up to the meso systems, and then up to the management systems at the macro level. And that's what we have done. So we've defined indicators for each of these systems, and we've pulled the data, right, from one subsystems and then add it into the other data, and then systematically producing the whole system measurement, the whole system measurements. Yeah. So that's actually how I feel that we should be measuring whole system outcomes and directing our energies towards improving those outcomes in each subsystem and then to get whole system coherent outcomes. So in summary, the problem of large-scale whole system transformation is actually a systemic challenge with numerous services and enablers by different teams in different subsystems, all needing to be concurrently transformed through time coherently, and people need it from us fast, right? So 25 years and I'm still trying to solve this problem. We aren't exactly fast, right? So because of that, I'm prescribing we need a cascade of interdependent models, preferably anchored using a forward-looking model of care, right? One such as the unified care model that is preventative, person-centered, integrated, value-based, place-based, right? And then direct our energies for data informatic IT models coherently towards supporting the unified care model, right? Ensuring that we can accelerate digital transformation that supports care model transformation. In attempting to do this, we will be extremely resource challenged. So, and people will need their local realities to be addressed, right? So I will do what I call model prescribed, but polarity ready, meaning to say we know what we want to get to the future, but take care of the immediate needs as well. It is an and management style, not an all management style. So last but not least, systemic implementation science methodologies can help us visualize the complexity, help us to take our path through the complexity in a much more easier way. All right. So with that, thank you very much for listening to my talk. I look forward to my other panelists' talk as well, and I'll have a discussion with you later.
Okay, thank you, Yokfan. So next, let's hear from Mr. Yuan's panel with a talk titled From Promise to Practice, Bridging the Efficacy and Effectiveness Gap in Digital Health.
It was working well earlier.
Yep. So, yep. Okay. Yep.
Good afternoon, everyone. And again, thanks for being here with us on a Friday afternoon. Kind of a rainy day, so maybe better to be here than outside. But thanks again for being here. Thanks for the invitations. So in the kind of like roughly 15 minutes that I have, I will try to share with you the importance to fully understand our ecosystems and the different stakeholders that we have. I'm going to use digital therapeutics as a use case to explain and to demonstrate the complexity of our ecosystems. So in maybe 1 minute, I'm part of NUS, the School of Medicine, the Wisdom Institute, which is the Institute for Digital Medicine. So in short, it's all about tech development. Most of them are AI-based. We look at the clinical validations with our clinical partners within, NUH, AH, and so on, and also about the implementations. Because I think this is, we mentioned about pilots earlier. I'm expert in pilots, but that's not good enough for us as patients to potentially benefit from these technologies, right? So we look at the tech implementations, and my background is not really in academia. I've just been 5 years with NUS. My background is more pharma, medtech, insurance, and advisory capacity also. So that's why you will see a bit of industry influence in some of my kind of like discussion point later on. So just to clarify, what are digital therapeutics or what are digital health solutions? Because if you open your mobile phone, we have about 0.5 million of mobile apps that kind of track more or less everything and nothing, right? From your Fitbit app to your Health 360 app, but all the way to what we call digital therapeutics. So digital therapeutics, simply speaking, that's my kind of checklist. If it's a software as a medical device as one, subject to regulatory approval, the interventions is delivered to the patients and not to the clinicians, regulated by HSA, FDA equivalence, and have the ability to collect real-world evidence, then is not just a Fitbit type of solutions you have, but it's what we call a digital therapeutics, right? So just keep this in mind. And to give a concrete examples, one of the few kind of success stories and best practices we have. So this is a SleepYo in the UK. So it's a DTX delivered through a mobile phone. We have a couple of different delivery mechanisms. This one is using a mobile phone. Was launched in 2018. And so looking at insomnia, sleep disorder, about 1/3 of us in the UK or Singapore, most countries, about 1/3 of us will have sleep disorder / insomnia, right? So basically, today you take sleeping pills. Tomorrow, we don't have the solutions yet in most of the Asian countries, but SleepYo, which is a digital therapeutics using CBT, CBTI, so cognitive behavioral therapy, and I is for insomnia. So basically, digital CBT basically can help you address symptoms and address basically conditions that you have when it comes to insomnia and sleeping disorder. Why I'm sharing this one, because it's kind of a straightforward solutions, is a digital way of using CBT tools and methodologies that are being used in practice. But in the UK alone, over 10 million of individuals have used the solutions. So I think at the end of the day, and why maybe we have these conversations, is about the impact at scale. 10 million of users have used the solution. So yes, it could be done, right? In Singapore, we'll be about twice the population, so maybe it's kind of an ambitious goal, but I think it's something we should keep in mind. So in terms of what we do, or what I do, part of the research institute, we are looking at every single tech solutions. We are looking at the different factors, the different kind of variables that will influence and impact either the clinical value, the clinical benefit that the tech can deliver to patients, to caregivers, to systems, to physicians, obviously. But we also look at the clinical side, the economic side, right? Because at the end of the day, someone will need to pay for any of the solutions that we have. And I think it's always the issue is that from a clinical standpoint, we see the benefits, but then so what? I need to see the use case, and we can't rely always on the same payers being the government for subsidies also. So we need to think about this kind of financial impact and the couple of different factors that will influence the economic value of your technological solutions. So how do we address this gap that we have, the translational gap, basically the gap between what we call efficacy in a clinical trial and RCT versus the effectiveness, the ability of your technology to deliver a clinical economical benefit in a real world environment, right? At scale, if possible. So one of the first things first, this is kind of what we are trying to do. I'm not saying we are successful. I think it's kind of a journey. But what we are trying is to, first of all, to understand the different stakeholders we have in our ecosystem. So here I'm just taking one, our healthcare practitioners. You're thinking about the nurses and the physicians and trying to understand really what are some of the concepts, what are some of the questions that they have when it comes to technology, right? And this is, I could have like 50 slides with you on just concerns that they have. So it's a matter of prioritization, but always what I see is, how does it work? Is this kind of a black box kind of type of solutions? How is it going to help me? How is it going to help my patients? And at the end of the day, who is going to pay and what are the evidence that you have? Oh, this was done in the US. Show me the evidence here in Singapore. This was done in Hong Kong. Show me the evidence, also clinical, but also on the financial side. So this is the first thing to understand really what is the problem statement and what's the agenda of the different stakeholders you have in your ecosystem. Until now, when you think about digital therapeutics, is almost kind of a black box. If you think about CBT is kind of a toolbox, and you have a few tools in your CBT, so cognitive behavioral therapy. You have a couple of tools in your toolbox, right? And for now, engineers, what they have done is I give you all the tools, and the solutions is going to work for you, right? And this is what we have seen in clinical trials. Most of the digital therapeutics tend to deliver clinical benefits, but we don't know which of the tools are more or less effective. So when you are developing your solutions, how do you allocate the resources? Which features, which kind of characteristic of a solution should you prioritize? The user and interface, is this important, not important? Until about a year ago, we were not really sure. We knew that some of the solutions will be effective, but we didn't know why exactly. And this again, I'm using like sleep disorder because again, 1/3 of us will be able to kind of relate to some of these symptoms. But the University of Tokyo, what they have done is to look at all these digital therapeutics, digital health solutions, looking at CBT, CBT high type of tools that are being used. And this is a high-level summary. I invite you to read the publications. But basically, they've looked at all the tools, and they found out the one that are really effective, the one that you should have in your digital therapeutics, and the one that, okay, is good to have, nice to have, but is not going to basically help your patients much. I'll just take one as an example because I don't have the time to go to all of them. If I look at sleep hygiene educations, I think, if I would ask all of you, is this really important to educate our patients, to empower the patients about what is the conditions and to understand why you're supposed to do A or B? I'm sure all of you will say, yes, it's really, really important. And this is kind of where we start. But when we look at the ability of such content and whatever kind of tools you're using for that to deliver a better outcomes, clinical outcomes to the patients, basically not much. It's good to have, but if you have only 5 minutes every day with your patients, because the interactions is not going to last not too long, what are some of the tools, what are some of the content that you need, or some of the mechanisms that you need to prioritize? Based on that work, maybe trying to educate the patients is maybe not the first thing you want to have. I'm not going to in the details, but relaxations. You will tend to think, yes, meditations, relaxations is a must, but in fact, it could be harmful for the patients for really, really interesting reasons. But this is my teaser. I'm sorry, I don't have the time to go to the details. I invite you to read the publications. So Then what we did is like, okay, clinical, we know we have to get to the right level of evidence. What about the financial, the economic evidence? So we published these publications about a year, maybe 2 years ago now, to look at all the clinical, the evidence. Are these solutions, digital health therapeutics? Let's assume we can deliver a clinical benefit. What about the economic benefits, basically? And so in short, most of the DTX, so about 18 of them that will meet our initial checklist, about 18 of them, most of them were either cost effective or cost saving, right? So not bad. But one of them, unfortunately, it's always about the nuance, right? One of them was cost effective only in one of the three countries of study. Let me deep dive on that. Basically, what we did, we looked at all these 18 DTX, digital therapeutics across the different countries, and we kind of mapped them as this kind of 2x2. I know that we all love frameworks, so I thought I would share also a framework. And we looked at, are these digital solutions more or less effective? But what about the cost? Is this like cost savings or not cost savings? So this is a digital health solution. So you would tend to expect all of them to be in the green box. Yes, we are going to save cost and we are going to deliver better care for the patient, right? But the first learning is that we had digital therapeutics, we had these solutions in every single of the quadrants that we had in our model, right? So that's the first thing. Again, I'm happy to talk about the details later on if you want. And the second thing is that if you look at the number 49, this was a DTX in the cardiovascular space. The same DTX was deployed in 3 different countries. It's the same mobile app, right? If I take a shortcut, the same mobile app. And the same solutions was basically, if you look in Europe, Taiwan, or Spain also, so Netherlands and Spain, could be more or less cost effective or could deliver better care or not for the patients. And it's always the challenge that we have, like for example, in Europe, you have a clinical trial in Germany, and then you expect to go in the UK, and is this good enough? We have a clinical trial in Malaysia, you come in Singapore, is this good enough? It's much more complex than that, right? So to my initial point that our physicians would want to see the local evidence in our local context, my quick answer is yes, that's a must, especially if you're looking at adoption at scale. And then we looked at the details of like, what are some of the costs that were taken into consideration? Because you say, yes, this solution is cost effective, but tell me what's behind. What kind of costs have you considered? Have you considered the maintenance, right? How much is going to cost you or me to maintain and to develop, the updates of the software and so on? What about IP and the cost of the solutions and whatever? Again, I'm not going to go into the details, but if you look, each of the column that you have here is basically a DTX, the different solutions. And what you could see across all the DTX, and I told you earlier, most of them were cost effective or will lead to some cost savings to the systems. But unfortunately, when you go in the details, you could see that we are lacking standardizations and consistency in terms of the cost and factors that were taken into considerations. So my question to you is like, are they really cost effective? I don't know, because we can't really compare. So this is also why we need more guidance, standardizations in terms of frameworks at the government level to help us understand what are some of the costs and factors you would want to see and the kind of economic value you would expect from my DTX, right? So then in our next paper, we wanted to understand this a bit further, and we interviewed, so we use what we call a group concept mapping. I don't know if you're familiar with the methodology. It's a mixed method approach. We basically interview 62 individuals, 62 stakeholders. You see the 4 groups here: public stakeholders. So this is across countries. It's not but just Singapore, it's Singapore plus. So public stakeholders, HCPs, researchers, and industry stakeholders. And we asked them for all the costs. I think we have about 79 different type of costs and factors that could influence the economic value of your DTX. We asked these 62 stakeholders to basically tell us, is this really important to you as a physician, as a policymaker, as a payer, important or not important, but as a researcher, for example, will you consider this cost in the day-to-day of your practice, of your research, and so on? And what you see here is the complexity of our ecosystem. So all these costs and the clusters that you see in the x-axis are all factors that would lead to your DTX to generate an economic value. Unfortunately, the stakeholders that are involved in the DTX development, in the clinical validations and the implementations have a different understanding, different appreciations, I would say, on how some of these factors should be considered or not considered. And we were quite surprised that our researchers, and a few of them were in Singapore, but there is kind of a huge gap when it comes to the more economic considerations about monetizations. I mean, earlier we're talking about commercializations, right? About the monetizations and the costs that are related to a DTX, right? So we wanted to understand why researchers will take or not take into consideration some of these factors that we know are going to make it or break it for the solutions you're trying to develop and to push to a market at the end of the day, right? And this is my second last slide. I can't share all the variables and the factors, unfortunately, because it's a work in progress. We're about to publish this paper, but we interviewed researchers, in-depth qualitative interviews, to really try to understand throughout the different stages of the tech development, what matters to you and what are the factors basically will you take into consideration, or will you take into consideration, sorry, and what are some of the factors that will influence your decision-making process on daily basis. Are we looking at just publications? Are we looking at IP? Are we looking at funding mechanisms? Are we looking at economic considerations in different, whatever might be the definitions of the different stakeholders, sorry. And what you see here is the complexity of what is behind basically a researcher, an individual kind of mindset about should I take into consideration, or is the awareness first, but should I take into consideration some of the costs and factors? We could see that is a highly complex systems, and this is just using a causal loop diagram to understand the complexities, but there are a lot of factors and variables that will influence someone, yes or no, to consider some of the cost factors. And so why is this important? Simply back to maybe why we are here today. It takes on average 17 years, right, for research, for whatever we might be doing. It's a use case, it's a publications, peer review, or clinical trials. It's about 17 years before, as a potential patients, we can basically benefit from these technologies. And only 40% of research basically reaches the patients at the end of the day, right? So I guess if you're here today, I don't have to convince you about this kind of efficacy, effectiveness gap, but it's just a call for us, all of us. But yes, we are working in silos in a way that's fine, but it's really important to understand the agendas and the different KPIs of the different stakeholders that we have in our ecosystems, and how whatever initiative and technologies we have could benefit each of these different stakeholders that are going to play a role. If you want to know more, I also have a QR code, like I got the... If you want to know more, I got the memo. About a year ago, we published a book with John Hopkins to try to go to the full process of what it takes to develop a technology, what it takes to validate an AI-based kind of digital therapeutics, and what it takes to implement, right? So can't cover all the details, but happy to answer any questions later on for the break. Thank you.
Thank you, Johan. And indeed, I think at this place, in this time and age, we kind of love QR code, because I'm about to make an announcement about QR code. And please keep your questions coming in on Poll EV. We're going to slash yes. There you go. Yeah. So yeah, I know as the only have got questions, we'll take them in mind and then we'll post them on Poll EV. I'd like to introduce our next speaker. Adjunct Associate Professor Sean Lam with his talk, Systemness in Healthcare, Harnessing Systems Approaches to Navigate Uncertainties and Complexities. Please.
Thanks, ISS, for organizing this and inviting me for this talk. Good news is I have more QR code for you to scan. Okay, so I'm going to turn the tables a little bit around so that I can better engage the audience as well, to start off with a question. Right, so before I do that, my background is actually more in operations, research, management science, quantitative side. Nowadays, they call it data science and all those. 20 years ago, we don't have artificial intelligence, data science, but it changes. But anyway, now I'm actually with health services research, so supposedly under research and innovation. And basically, we look at health systems improvements as a whole, and also more micro hospital systems improvements. So my talk is going to be slightly towards this idea of systemness. How do we move a system into having this quality of systemness, and what are the kind of techniques that is already available throughout my whole journey of learning about this analytics landscape that could actually be helpful to look at this problem, or we typically call it complex problem or wicked problems, using some of these existing methodologies and thinking process, right? So I will start with a question. So if you have a magic wand and could instantly fix one major challenge, what would it be today? So I completely agree with what the story that Bertia shared, because my own personal experience is exactly the same. So let me just move on to this. Where is it? Oh, sorry. Oh, it's closed. Just now I opened it. Okay. Sorry. Give me some time. If you're able to respond, you can go ahead to respond. Okay. Right, great. I see some responses already. So as you key in your responses, I was just about to say that I have a very deeply personal experience as well as my mom. So that journey was actually very sobering, I would say. I am from the health system, and I completely agree with what you say. I'm not going to ask to poll you who agrees with, because I guess 90% of you would have some form of contact with the health system, whether as a caregiver or as a patient. And my experience is a caregiver for elderly patients, so frail patients. And exactly, I mean, those examples that you gave are very relevant, still very relevant. So we have a lot of work to do in terms of how do we actually unravel this complex system. So even myself, I realized that it's pretty complex. In comparison with someone outside, like my sister or my relative, looking at the system from the outside, right? So I guess all of you would have this magic wand, and you're supposed to only have one magic wand, but if you go in multiple times, you actually have multiple magic wands. So let's look at this together. Okay. I only have 28 responses. I think easily there's more than that, right? So feel free to have multiple magic wands as well. Okay, so what this does is actually just to, it's a word cloud. So those who have more higher frequency of words, it will come out more, bigger, it will be. Okay, so reduced waiting time seems to be very, very important for all of us. Patient empowerment, manpower, solve the manpower issues, cost, affordability. Cool. Right, so these are some of the, essentially, these are very important aspects that we are trying to grapple with exactly. And you can actually see that they are somewhat related as well, right? So if you're able to deal with a problem, manpower, for example, the reduction of waiting time could be due to this constraint, could be due to a capacity constraint. Affordability, cost, and if you're able to empower the patients to be able to do some of it, you may actually reduce the cost and increase affordability and so forth. So they're all related. And there are multiple outcomes there. You actually see that there are multiple outcomes like cost, affordability, waiting times, stay healthy. Wow, unlimited beds for patients. Okay. So that's a talk for some other topic. So you may not want to be a patient in the first place, right? So really, so if you can keep people healthy, stay healthy, that's good, and so forth. So what we are trying to do is actually not so simple, as you can see, that essentially we are grappling with. I think you can continue to put in a challenge. I mean, I come from an evidence-based kind of side of the story, so I wanted to have some objective evidence of our thoughts as well. I'm just sample size of 1, and Bertia is sample size of 2. So, but it's good to keep coming, providing me with some of these insights. Okay, so what we have just seen is exactly what we are also trying to grapple with. The whole problem is not one single objective. It's not economic, certainly not just economic, right? So there's multiple array of issues that we have to grapple with. And one of the framework that we find pretty useful to think about this whole problem is from the perspective of Institute of Medicine. They actually propose a way to look at healthcare systems objectives. So what they have developed over the years now is called a quadruple aim. I think there's a quintuple aim that just came out. But we look at this quadruple aim, right? We talk about patient satisfaction, patient experience, waiting time, that's important. Patient outcomes, that's important. Ultimately, it's about that. But yet, we need to have a sustainable system where all our resources are limited. We cannot have unlimited base, by the way. So if we can, then, I mean, we have the magic one, perhaps we could. But given limited resources in the Singapore context or any other countries, how do we have a sustainable system, right? Sustainability is important, cost effectiveness is important, as well as how do we do the most good for the most number of people, right? So that is population health. So we always say, what is appropriate care? And whether appropriate care is actually optimal care for an individual, that is open for debate, right? Appropriate care for a population. So these are all balancing and trading off kind of objectives. They could be conflicting objectives. And then finally, what I like about this quadruple aim framework is that it actually recognizes that healthcare is a very deeply human-centric enterprise. That means if you want to take care of the patient, you've got to take care of the service provider, right? Because there is always this interaction. As so far as I can see, we are not in the near horizon. We cannot have a completely automated kind of doctor systems or self-driving doctor or whatever they call. I don't think it will happen. But it is always a human-centric enterprise because there is also the social behavioral kind of interactions that can induce health changes and so forth that only the human touch, the human empathy can actually realize. So that is the fourth aim that IOM brought into the picture. The fifth aim that I mentioned about 2 years ago, a paper actually suggested equity in health is important, which is certainly something that we have to consider as well. So it's multiple objective, multiple aim. It's not a simple problem, yet we have to be able to look at all these objectives. How do we do that? And in health economics, we always look at cost effectiveness, for example. That is one aspect of it. So if we were to always base on that, I'm certainly appreciative of the commercial angle to that because you need to really find a reason to sustain it. But that when we ask for that reason, I think it has to go beyond just cost effectiveness. It potentially could, we need to challenge the assumptions of how it's going to impact the system as a whole and how to actually, in the evidence-based methodology, to be able to evaluate that. I think we are seeing more and more of those assessment and evaluation, but as we expand the scope even further, it's going to be harder and harder. So we need to, as Yuan pointed out, leverage on both qualitative and quantitative methodologies to provide the evidence. It's a justification for why it's useful, right? And not useful just for the patient, but useful in the context of achieving the multiple objectives if possible, but that is hard to do. On the left, I just show some examples that we have in translating this idea of quadruple aim locally. I just mentioned some of this is the ability to surge demand when there is a pandemic, when there is a sudden increase of demand that results in a squeeze in the health system. The ability to look at use of technology to reduce the need for manpower. So to have, infinite manpower may not be the solution, right? So technology may help to actually improve the efficiency and effectiveness of the care system. Right siting, where patients should be taken care of at the right place, given the right kind of interventions at the right time, right? So sustainability is a goal that we also aspire to now. Now there is always this idea of a net zero carbon hospital. So we are trying to move towards that, but requires engagement with a large number of diverse stakeholders to be able to achieve that. So it's multifactorial and multi-objectives. And we think, I think as a whole, all of us agree that we have immense potential in being able to leverage on new technology. And to do that in an evidence-based manner, we need data. So I think some of you may have heard of this. Data as a new oil is not a new term. That is able to derive benefits out of data from all the way from the molecule level to bench side to bedside to the population level, even to the systems level and the country level and so forth. AI as the new engine consumes this. So which means that your data has to be sufficiently clean. Otherwise, if you imagine a car that's running on low quality oil, that car will spoil easily and cause an accident in that traffic system or wherever that is in. So that requires good data, but AI certainly can be viewed as an engine that powers the next phase of transformation in our health system. But how can we do that so that we don't have so many accidents on the road? I think that's something that you figure out. Just a word that in order to do all this together to achieve systemness, they have to start from a very, very early stage. That the problem and definition and the needs should be defined together with the stakeholders. And the modeling is not an individual modeling, it's a group modeling. What Luann shared earlier, the group concept building phase is really bring all the stakeholders, the relevant stakeholders, the KOL, together to bring together the mental model to fully understand the complexity of the problem. Then we look at using more quantitative techniques to generate those evidence. Right, so it's really, we need a village to actually be able to build that and equip real world, to be able to handle the real world complexities. So that's my final slide. Thank you for your attention.
Thank you. So now may I invite all our panel back up on stage, please. And do keep your questions coming in. I know you have a lot of thoughts and comments. I am sorry to say, please do scan your QR code again to pose the questions. Or if you have some questions, we have roving mics that you can ask them. Yes, fine. Yeah, just Sean. Okay, so now I will hand the time over to Shailu, Chief of Digital Health, to moderate the panel.
So very good afternoon to all of you. I think we didn't do justice in giving our panelists enough time to be talking about such a complex topic. I think you will definitely agree that we should have given you more time, but probably we'll have more of such series again this year. So let us once again put our hands together for our distinguished speakers and panelists who are practitioners of systems thinking and transformation leaders. So we have Glenn, Sean, Johan, and Yopfan with us today. And I am Shailu, Chief of Digital Health, and your moderator of today's panel discussion. Like most of us here, I come from the healthcare industry as well. And I worked at various hospitals in Singapore, including Parkway Hospitals in India, for almost 20 years, supporting hospital administration, operations, and management. So before we begin with our panel discussion, let me share some of my thoughts about this interesting topic. You heard a lot about complexity, and you saw some scary data that finally Glenn presented to us. Okay, let me try to brighten up the mood. Let me share some good news. I think we spoke about it before the session. Singapore's healthcare system is the most efficient in the world. I repeat, Singapore's healthcare system is the most efficient in the world. You might be wondering if this is true or false. True? True. It is indeed true. And this is from the 2023 Bloomberg Health Systems Ranking, demonstrating a strong healthcare system with efficient resource allocation and good health outcomes. According to the Economist Intelligence Unit, Singapore has the second best healthcare performance in the world. So when we are so well ranked globally, why are we still here discussing this very complex topic will be the question. Well, like all good stories, there are heroes and villains. For those of us who are actors in the health system, and dealt with its dynamic complexity, are we not often surprised by the behavior of the system, its challenges and evil problems, including the behavior of the stakeholders in the system, similar to Betia's purpose experience, which all of us heard earlier on? We know that the reality is messy and there is no magic bullet. Singapore's success in healthcare is built on a panoply of measures developed and refined over decades. The digitalization of healthcare services is a major shift in the manner in which healthcare services are offered and managed. It is much more than the adoption of digital tools. Just as Yopfan shared earlier on, studies by big consulting firms such as McKinsey, Bain, and BCG have consistently shown that success rates of transformation efforts have been staggeringly low. Care success rates falling between 4 to 11%. 4 to 11%. Why is that so? So again, like Yopfan mentioned, should we be taking a step back? And do we need to think systemic? Perhaps understanding and acknowledging that systems contain relationships and dependencies. I think Sean spoke about it. And before jumping into adopting digital solutions and transforming digitally. Now, given this preamble, let's dive into the panel discussion and explore how one has to unravel the intricate web of systemic complexity and its implications for digital transformation. So here's my first question, and it's for Johan. Johan, your talk clearly highlighted the challenges in tech development, from concept to reality, and you showed us the research to practice gap. We would love to hear your views on pilotitis and scalability. Do you think there is a lack of sufficient cross-pollination and collaboration between clinicians and technology experts to ensure the successful adoption and scalability of pilot projects, especially digital solutions?
Good. So, thank you. How long do I have to answer your questions?
That's a very good question. Probably 2 minutes.
So maybe first of all, I think just to come back to your point about Singapore being one of the most efficient healthcare states, I think we should not forget that, because we tend to look at the inefficiencies in our systems.
Absolutely.
But let's keep this in mind. I think it's really, really important, because as soon as you leave our borders, and I'm not talking about Malaysia, I'm looking at across the world, the issues that they are facing are really, really different than what we are facing here today. Having said that, obviously we could do much, much better. And I think to your point about pilotitis, we did write an article on that maybe 2 or 3 years ago to align the issues of going from one pilot to the next pilot and to the third pilot and so on. And I think at the end of the day, we are a small country, right? So we do tend to have access to most of the stakeholders in our ecosystems if we would want to have face-to-face conversations or the Zoom conversations and so on. And we most likely know who are the experts and so. But at the end of the day, we tend to work in silos, right? And I think this is not unique to Singapore. It's not because we want. It's just, for me, it's about KPIs. KPIs drives behaviors. And just like last week, I was talking to a physicians at NUH, and I was really, really entrepreneur, or for my definitions, like entrepreneur type of clinicians, looking at always the next things, innovations and so on. And I was like, how come you're so innovative? Is this driven by your own personality, or how, part of the KPIs? And it was like, frankly, as a clinician, researchers, clinicians, I don't have much KPIs about innovations or trying to look at new cool tech and so on. It's just driven by his own interest, kind of personal interest and passions. And I think at the end of the day, we all have KPIs, right? And unfortunately, for some reasons, KPIs have not been well designed that could drive collaborations across institute, across teams, across, your clinicians, and we are researchers with the government and so on. I take HSA. we have ongoing conversations with HSA, like to understand some of the requirements we might have when it comes to technology and so on. But in which countries could you say that I'm going to call the FDA to get a feedback on what's coming next in my technology? We can't have that. So I think we are quite lucky in Singapore. And so I would highlight and encourage everyone to try to break down some silos, but that may be great for all of us here in the room. But if we want to do that at scale, I think it's about KPIs. So let's just review and update our KPIs and it's back to the capitations models that we are about to embrace, I think.
Oh, great. Thank you. That's a different, new perspective that KPI drives the collaborations. So good. I'm going to move on to the next question, and that's for Sean. Sean, again, you spoke about decoding challenges and systemness, interdependencies, right? And what interested me was your last slide where you spoke about, let's do this together, right? So my question to you is about building a systems thinking culture. How do you think healthcare organizations can cultivate a culture that embraces systems thinking across all levels, from leadership to the frontline staff?
Thanks. Culture itself is a big problem. We all know that culture is strategy. You said correct. Culture is strategy. If your culture is wrong, whatever your strategy is doesn't matter. It's just good food for the culture. But now you're asking me about a strategy to drive that culture. Okay. So there's a feedback effect there.
From a researcher's perspective.
No, I mean, my thought is that it is a multi-level problem. Again, I think we always think in terms of when we do this kind of management problems, right? There's a multi-level. There is the macro level, meso level, and the micro level. And the macro level is kind of like the strategy level, and then tactical level, and then the operation level. So it's all similar idea. And to break down a system into like divide and conquer approach. So at the lowest level, okay, let's start with highest level. Let's respect the highest level. There has to be an understanding and kind of like a certain level of knowledge that there's complexity is present and systems kind of thinking tools, methodology will be useful, bring together stakeholders and so forth. And I'm sure at that level, everybody is aware of because at the MBA classes, graduate classes, it is all taught. So the thing is that at that level, if it's being embraced, subsequently, there will be sustainable resources to be able to deal with that problem with a broader base that is looking at the individual problems, maybe at the cluster level and down to the individual hospital level. I think at every level, there are different. I didn't have a chance to show those slides, but basically it's the same idea. Okay. So meaning that I think one of the key enabler is, I would say, education at different levels of education. Okay. Yeah. Okay. And also ability to, I think this is very important, KPI, the incentivization. Because if you say something and you do another thing, nobody will believe, right? Right. So if you are saying we should collaborate, but then your KPI reflects that I'm going to evaluate you individually, that's something wrong. So all this have to permeate through the organization. Yeah.
Might be Yukfan, you want to add on since you're from KTPH and directly from the hospitals?
Yeah, this actually is something that I'm very passionate about. Just a few days ago, I was trying to teach a class about trust. And then the mirror image of trust is worthy of trust, right? Trustworthiness. So for example, you'll come to me to have a system thinking class, right? You can trust me to give you a system thinking class, but you wouldn't come to me for eye surgery, right? So you wouldn't trust me for eye surgery, right? So I'm not worthy of trust if I were to perform eye surgery on you. So same with systems thinking, we have to be very clear, right? The ability to think systemically and to have systems thinking capabilities does not mean that we adopt the systems definitions that will bring us all to the same outcome. So all of us are systems thinkers. If you are going to renovate your house, you're not going to put a kitchen and a refrigerator in every single bedroom. You will make sure that your whole house only has one kitchen. So you're already a systems thinker, just that you're not a system thinker for healthcare, right? So So when Shailu asked this question, so how do we permeate systems thinking culture across the whole health system? Then the question is, what is the system that you want people to think systemically about, right? That's the first thing. You have to align some sort of definition of a person-centered system. That's the first thing. Then the second thing is, who needs to make decisions to get us to such a system? Those people who need to make decisions on a daily process, daily basis, will need systems thinking and awareness of the models that we need to use system thinking to drive towards. And whoever does not have that knowledge, we educate them, like Sean said. Educate, model, teach, work together to impart alteration of our systems thinking capability from daily systems thinking towards the models that bring us to better healthcare, right? So I would analyze that problem that way, but not everybody will need to be making decisions, right? They can live behaviors using very simple rules, right? Eisenhardt best describes simple rules that we can build into the system, and then people can be happily emerging the qualities we need from our healthcare system. Yeah.
In fact, you brought up a very good point, which we've not discussed here, is what is the system and health system. So I think for many of us who may not know, a good report to read about and know what is a health system is the World Health Report in 2000. So that's when that was the first time they actually spoke about what is a health system and sort of articulated the concept. So I think we need to start there and then go into systems thinking and then so on. Great, thank you for that. And then now let's move on to our tech guy. And that's Glenn. I'm going to fast forward a bit to our near future, right? You shocked us with all those numbers and almost 600 over systems, right? My next question is about EGH, Eastern General Hospital. It's going to be a digitally enabled hospital, built from ground up as a purpose-driven phygital hospital, leveraging digital twin technology. Being a new hospital, it will not have legacy systems, right? Happy. And related, and we should not be seeing the related interoperability issues. Yet, do you foresee emerging challenges? If yes, why? And what could they be? And any strategies on hand to tackle them? Sorry, it's a long question.
I think I need 20 minutes.
How would you put this in a capsule format?
Efficiency. I am very confident that we are one of the most, if not the most efficient healthcare system in the world. It took us 9 years to build Woodlands, but let's cut some slack. 2 years shifted MRT track, 3 years COVID, right? So that's where the time went. But I have an interesting joke. There's someone in this room who was amongst the first pair of boots with me on the ground at Expo when we built the community care facility. It took us 3.5 days to bring up the first, gosh, I can't remember now, 480 times 2, 960 beds.
Wow.
3.5 days, 960 beds, 2 halls in Expo. So when you compare that, 960 beds, and it's by the same Woodlands team. The same Woodlands team building a hospital is the same Woodlands team that brought up Expo. What's the difference? There are processes that goes in there that we have to execute. And some of these processes are a necessity of our country's values. Example, we are very allergic to any corruption or conflict of interest kind of behaviors. So procurement will always come laden with all kinds of approvals. Do we have too much approvals process and steps? Yes. I complain about it. They exist because of our values that cannot possibly be wrong. But when we were doing Expo CCF, because it's wartime, we could get approval with just one email or one WhatsApp message. Yeah. So the spirit needs to be met. The letter needs to be executed. the means and the mode, we need to figure out how to get more creative. And with that comes KPI and culture, right? I think we nailed it. These two are the two key elements, but it is really hard. It is really hard to figure out how do we culturally transform and use KPI to incentivize and drive behaviors. And the system is not short of smart thinkers. There are many clever, intelligent people in Singapore public healthcare, right? So we have the assets, we have the resources, we have the funding, we have the right brains. The culture and the KPI to align the efforts is important. Now, coming to EGH, the term phygital, I didn't like that term. I know who created that term. It really just means a physical state that allows digital capabilities. But actually, if you think about it, as I mentioned just now, even the oldest hospital in Singapore can claim phygital because our network competency at every hospital level is beyond what a normal building in Singapore will do. And through the COVID experience, telehealth, telemonitoring, remote capabilities, we have them across all hospitals in Singapore as well. When EGH embark on this journey, they will similarly have to go through processes to secure funding. They will similarly have to go through procurement processes to make sure that we are whiter than white and we are kept honest in our steps. We cannot assume that everybody who is involved in this process will be whiter and white like us. As you have read in papers that there are always surprises of certain practices. So as a result, all these processes need to be in place. And EGH, end of the day, is part of SingHealth. In us trying to arrest fragmentation of system, you will find that some of the core systems that need to be shared across SingHealth, EGH will extend and inherit. Even if EGH is to start a new system that is in an innovative category, and if that proves to be successful, the intention will be to proliferate EGH system into other healthcare institutions as well. So there's that two-way direction of how we spread best practices and innovations. So while EGH is going to be under development as a digital innovative hospital, there were many before them and there will be many that comes after them. Innovation is a trait description, is not a label on any entity. It is something that we all have to embrace as part of our spirit.
I like the way you spoke about innovation. Yep, I definitely feel we should embrace that. Now moving on to Yok Fan. Again, very happy that you shared about the systems transformations, the whole systems transformation, using your comprehensive frameworks, the playbook, deep learning and problem-solving framework in specific, which are very people-centric, integrated, and value-based. But what about complementary approaches? How can other methodologies, such as design thinking and agile, which I think one of our panelists did speak about agility, how will this complement systems thinking to drive healthcare innovation?
I think all are important, but at different times, different things become important. Although we are Institute of Systems Science, we really value systems thinking. I think in my 25 years and in the last 10 years, trying to solve the problems that different stakeholders bring to me, right? So that has got me thinking that at different times we need to use different skill sets to be able to solve the problems that are going to get us to better outcomes for residents of Singapore as well as patients of hospitals. Yeah, so that's why in my health system transformation playbook, the fundamental sciences that anchor the design, the three-step process of storytelling, group model building, and then pathfinding are actually based on design thinking, systems thinking, and then complexity pathfinding, complexity management, as it were. So for example, if you listen to the stories, you are actually looking out for extreme users. You are actually looking out for human-centered potential problems that needs and challenges that we potentially can meet, right? With empathetic solutions, which could be a service, which could be a product, which could be a technology, right? But it has to happen within this framework that you have already decided that that is your model of care. That's your business model that's going to bring you to better outcomes for residents, for better outcomes for patients. And then you break down what I call demand-sided systems and supply-sided systems. So demand-sided systems are people, right? Patients, residents. But supply-sided systems are institutions, clinics, providers, partners, insurance companies, technology companies. They're there to meet the needs of demand-sided systems, as it were. So in the system, you look at the demand side using design thinking, but then you then have to look at the system side. What technologies are going to meet the needs of people, staff, people and staff, right? Then you have taken care of both of those things. But that only gets you to an innovative model that you want to put out together at scale. But that doesn't take care of the resource challenges. It doesn't take care of the local politics. It doesn't take care of the timing. And that's why you need to be very politically savvy. You need to know the love, power, justice issues. And then you need to find a path together, hopefully with authentic conversations with your stakeholders, prioritizing what can be done now, where there's certainty or agreement. If there's agreement, move, right? If there's no certainty, pilot, right? And then you figure out when to do what, and then try to get to the ideal model that you have built together with your stakeholders. So all three are needed, not just design, but systems as well as complexity management toolkits and technologies. So you really need to be a master of a whole plethora of tools, as it were, right? And capabilities and skill sets, yeah.
So you would weave it into the framework itself.
Yes, so the framework, if you look at the HSTP, I think it describes the different steps and all the skill sets that you need to bring in. You don't have to know everything, but you have to master the process of change and transformation and bring in the relevant skill sets that you do not have. Not all of us can learn all skill sets, but you can preside over the transformation process, right? And then bring in the relevant skill sets to help you, yeah.
Thank you, Yukfan. I think we're going to move into the Q&A segment in the interest of time. So we shall take the Paul EV questions from our audience. And we probably are going to see it being flashed here, and I will read it out for our panelists. So while it is here. And the first question we have is, I shall read it out for our panelists' benefit, so you don't need to struggle and turn behind. So in your opinion, what are the pertinent gaps in hospitals' way of tackling complex issues? And therefore, how could we better adopt a systems approach? Who would want to go first? Or who would want to take this question? Yes, Johan.
So, okay, I would
The
try
gaps.
to. Yes. So I want to share a quick story with you that that I didn't have in Singapore, but just to share like back to maybe the cultural aspects. A couple of years ago, I spent like some time in India, and I was talking with I was with Medtronic medical device at the time, and I met one of the endo in India, and we had a concept. And I came to that meeting with the physicians with one slide. I had the concept on paper. And I was talking to this endo, and I was like, look, this is a concept. What do you think? It was like, I love it. Let's start tomorrow. I was like, well, doctor, this is just a concept. I have nothing beyond that slide. And then like 6 months later, we had basically the full concept running in his hospitals, right?
Wow.
This is something, unfortunately, that I only had in the developing or soon to be developed markets because of being so resourceful and being willing to address some of the challenges and inefficiencies. I'm not saying that
whether leaders or frontline workers can take to foster a systems thinking mindset in healthcare. We start with Glenn.
Yeah, I covered it just now. The word for me is collaboration.
Collaboration. Okay. Sean,
Similar stakeholder engagement.
stakeholder management. Okay, engagement.
I would go maybe more at the kind of tactical level of what you both said to patient centricity, because we tend to all be or claim be patient centric, and it's kind of a marketing. Sorry, it's more than a word, but yeah, a marketing tagline on the website. But I would invite every one of us to have engagement, proper engagement with patients and users, and having collaborative approach.
For me, is to deeply listen to your stakeholder, where they are coming from, and then put yourself in that perspective. Imagine the perspective so that you can see the world from each other's point of view. Yeah.
So we heard that was quick. It was collaboration, patient centricity, stakeholder management, and the perspective also. So this is a good actionable takeaway for our audience to deal with the complexity within the hospitals or organizations that they come from. And I shall wrap up our panel discussion by sharing a few concluding thoughts. I suppose, like me, many have come late in life to appreciating systems thinking and realizing that there seems to be an urgent need for a paradigm shift, a need in the way we think and work, as you mentioned, and in order to address these wicked challenges in healthcare systems. So while dealing with some of these systemic issues, is it our reductionist view of the world that is making us feel a sense of inadequacy? This question comes to my mind. Perhaps it's just a lack of training and not being equipped with the right tools, which I think some of you did mention about training, and methods to deal with the complexities. So here at NUS ISS, we do offer certificate programs in systems thinking and root cause analysis for health services specifically. The details are up there to help one connect the real pragmatic challenges and issues with more complex ways of thinking and less reductionist ways of approaching problem solving in health systems. We will also soon be launching a completely new blended learning module called Digital Lean for Health Services. So I know we in the hospitals love Lean. We are going to take it to the next level called Digital Lean, and it's going to be completely blended learning, which will build the required capabilities and skills in healthcare workforce at all levels to be able to tackle complex workplace issues and contribute to the digital transformation efforts of one's organization. And finally, I would love to touch upon this topic, which I had briefly discussed with Yokfan earlier on. Arising out of this seminar and discussion, we do see the need to create a community of practitioners in Singapore. We discussed this with Sean too earlier, so I think it's coming to Glenn and Johan as something new. But we really want to come up with this COP in healthcare systems thinking with your support. So we would be happy to set it up and drive, getting in the right think tanks and then the leaders to support us. So that's something that you could look forward to from us. So I would, with this, hand it back to Bethia.
So thank you very much for this insightful discussion. Our panelist has given us a lot to think about, a lot to reflect on. I'll be taking away with me, and I hope you too, fresh perspectives and new inspirations to apply in our work. So a heartfelt thank you for all our speakers for sharing their expertise so generously, and to you all, our audience, for your thoughtful participations and questions. So a also special shout out to all my colleagues at Digital Health and everyone at NUS ISS to ensure the success of the first seminar of the year. So please join me in giving our speakers another round of applause.